So let's move on a little bit into something where I think there's a lot of agreement internationally, and that's the treatment of metastatic disease. I think that at this point in time, based on the Cleopatra data, most people will give THP, trastuzumab, pertuzumab, and a taxane. And I have a feeling that the taxane, what's used, may depend on what part of the world you're in. Do most physicians in Europe use docetaxel as opposed to paclitaxel?
Can I start?
Please.
Well, actually, to be very honest, in Germany, most of us use weekly paclitaxel. We like that because it's very effective, the side effects are quite low. So 3-weekly docetaxel is not the most used schema in Germany for treatment of metastatic breast cancer. Now the problem is, this is how the study was done. Not the problem, because this is how the study was done, and then obviously this is the labeled definition. So there is a second trial which has used weekly paclitaxel and was also positive. So most of us in Germany, we use the combination, the double combination, trastuzumab, pertuzumab with weekly paclitaxel in the metastatic setting.
How do you schedule your paclitaxel? I think one of the difficulties with many people is that you, if you give 3 on, 1 off, you can't, they have to come in on their week off to get pertuzumab variably.
Okay, yeah.
Right, that's a good point. It's an excellent point.
Yeah, that's a good point. Yeah. So as you might know, we are very, very trained in doing neoadjuvant trials, and you remember the Gepasepto trial, which was published earlier this year in the Lancet Oncology. And in that trial, we used in both arms continuous 12 weeks of weekly paclitaxel in one arm, and the other one nab-paclitaxel. By the way, it was positive for nab-paclitaxel. And also we used the double combination the way it is used. So the patient, yes, were coming weekly to their taxane regimen, and they were receiving the double combination in a 3-weekly fashion.
But you can't do that forever in metastatic disease, so you have
That's
to give
correct.
a break. So
yes, that's
we've
correct.
tended to go, maybe a couple cycles with 3 on, 1 off, and then switch to 2 on, 1 off, which is less drug, but what do you do?
Practical, yeah.
Yeah,
that's
I agree.
practical. Yes, I agree.
2 on, 1 off is practical.
I think basically we have the choice here,
Yeah.
weekly paclitaxel or every 2 weeks. But usually we would like to do 3 weeks out of 4.
Yes.
But for the reason you mentioned, 2 weeks is more easy for the patient, so
Yeah.
but less drug.
Yeah.
So the next question is really second-line therapy. I mean, in the U.S., I think TDM1 is clearly the standard of care. Is it the same in Europe?
Exactly.
Second line?
Exactly.
TDM1
Yeah.
second?
Emilia, I was part of the Emilia trial, and
Right.
I was very impressed when I saw those data. And I think that is still one of the standards we have to beat.
Right, I agree. And so lapatinib, capecitabine use, has that gone down in Europe? I know in the U.S. it clearly has.
The development of TDM1 push lapatinib-based therapy, let's say,
Right.
to later
later
line
lines.
of therapy in combination with chemo or in combination with trastuzumab.
Yeah.
So both approach was pushed a little bit late.
But I know countries in Eastern Europe where virtually TDM1 is not available because of the economic problem, and they are still in the standard of care. One of the possible standards of care is the combination of lapatinib and capecitabine.
Okay.
Well, I think when we give it, we usually give all 3 drugs, trastuzumab, lapatinib, and capecitabine. That would be even
like
harder
that.
in some of the countries where they don't have a lot of financial issues. But
Right. So the last question before we move on to novel therapies for HER2, which is very exciting data. Really one of, I think, the big disappointments of the last year that we kind of hinted at a little bit was the fact that Marianne was not a positive trial. And again, as we know, Marianne was a study of docetaxel, trastuzumab versus TDM1 alone versus TDM1 pertuzumab in first-line therapy. And essentially, the progression-free survivals were all within the 14 to 16-month range. None were statistically superior to the other. And so the question is, why was that negative? And why was that supposedly a negative trial?
I think I would like to do here a general comment. TDM1 is a superb drug in terms of efficacy, in terms of side effect, and tolerance for the patient. And due to that, I think there are, for me, as clinical researcher, is a lesson. When we have a superb drug, we started to think to ask the drug to give superb result, super result, even more than the drug could give. Because going back to your question about neoadjuvant, a little bit less than expected. So I think TDM1 was giving in first line in the neoadjuvant setting. This is a targeted chemotherapeutic agent. So I think what we observed is what we should expect normally. But due to the really very good result in second line, later line therapy, we expect more in the first line, more in the neoadjuvant setting, and we face now the result. So TDM1 is a superb drug, is active drug, but we should not ask to this drug to give outstanding super result.
Right. No, I agree. But now we're caught because we have THP, which is superior to TH, and we have TDM1, which is equivalent to TH.
Yeah, but
so we're kind of stuck. We're now, what do we do? I mean,
I think the standard of care based on the survival result of the Cleopatra trial is the first line therapy for metastatic breast cancer. But I should admit that 10% of these patients only received trastuzumab in the adjuvant setting. That means 90% didn't receive. And that's the problem in this trial. Nevertheless, if we take the whole package of dual HER2 inhibition with taxane, I think is really the valid option for first-line therapy.
And you know, the thing is that Marianne really did include 3 times more patients who had been exposed to adjuvant trastuzumab. Exactly. So these cross-trial comparisons are difficult because we keep marching ahead with our standard treatments, and then the trials, of course, just suffer from having been developed, you know, when they were. And so I think that the bottom line is that in the future, most people will receive pertuzumab in the early stage setting, so this won't really be an issue. And hopefully, we'll just have increasingly less patients arriving into metastatic disease.
Well, that's in that vein. I mean, I think there was data just recently published in JCO where they actually looked at the response to TDM1 in patients who had already had pertuzumab as first line, and it was not as good as you would think. Do you guys have any comment on that?
That's what I thought too. I reviewed that paper before it was accepted, and I thought, well, it actually was interesting. It was MD Anderson and Yale. They went back and looked at their data sets and said, okay, you know, who had previously had pertuzumab? And people still had a response, and there was still a reasonable PFS, but it wasn't very long. And it's interesting. I mean, the more treatment you give before you give your new drug, the less well it's going to work. You just develop sort of all sorts of resistant mechanisms, and I think we all expect that. Exactly. But I think the paper was still important because it showed that you could get some benefit from TDM1 after pertuzumab.
So you look at it in a positive way. I agree. I think it's more of a positive spin.
And it was a retrospective assessment.
Correct. It wasn't really prospective data.
Can I add
Please
one
go add
more
one more
comment?
before you go on. Yeah.
I would like to add one more point, Adam. We have learned from the metastatic Marianne trial and the neoadjuvant Christine trial that we cannot beat the double combination trastuzumab-pertuzumab with chemotherapy. I think the wisest way is going to, given the answer was given, will be given by the Catherine study, because in that study we use the optimal anti-HER2 therapy with chemotherapy in the neoadjuvant setting. And in patients who have residual disease at the end of the neoadjuvant therapy, which are the ones who have the highest risk for recurrence, are treated either with the standard of care, which is trastuzumab adjuvant, or with TDM1. That study has been finished. We're going to see the results, and probably, if the study will be positive, we know the answer that in trastuzumab-resistant patients, then we might use TDM1, and that might be the wisest sequence. So let's wait for that.
Right. No, it's an excellent design. I hope that works. I mean, I think we're all looking very forward to that.